All right. Good afternoon, and thank you for joining us today for the USC Institute for Integrative Health and Wellness Symposium. This is a very exciting topic, and we're very lucky, very fortunate to have some incredible presenters that are going to be providing past advances and future perspectives about Ibogaine. We have doctors Kirsten, Cherian, and Dr. Deborah Mash that will be our primary presenters today. And then a Q&A fireside chat will be moderated by doctors Charlie Kaplan and Ken Alper. So thank you so much for attending today and participating in the symposium. Our mission with the USC Institute for Integrative Health and Wellness is to promote the health and healing of individuals, families, and communities that we serve through the advancement of the practice of integrative health and the science upon which it is based, and the education of the healthcare practitioners and our USC community and other communities surrounding our university and in the country. Our vision is to transform healthcare by establishing a collaborative, holistic paradigm that promotes health and healing and integrates all aspects of human life, physical, emotional, mental, spiritual, cultural, social, and environmental. We'd like to do a land acknowledgement that the Institute for Integrative Health and Wellness in USC and Children's Hospital acknowledges our presence on the traditional, ancestral, and unceded territory of the Gabrielino Tongva peoples. We recognize that these peoples were forcibly removed from their homelands, and we take this opportunity to acknowledge the generations that have gone before, as well as the present-day Gabrielino Tongva people. With humility, we recognize and respect all Indigenous people, their histories, and their ties to the land. We pay respect to their past and their present, and let this acknowledgement serve as an ongoing reminder of the original inhabitants from where you reside. Please use the QR code here for the activity code for an EADS member so that you can collect your 1.5 units of continuing education. And you can see it must be submitted within 24 hours to receive credit. If you have any troubles getting credit for your participation, please reach out to us and let us know, and we'll be helpful with that. As you might have seen from our flyer, this is in dedication to Dr. Nolan Williams, who recently passed away. Many of the colleagues on our symposium today are very close friends and colleagues. Dr. Williams, he was an incredible innovator and pioneer in this space, and we wanted to dedicate this symposium to him, his memory, and his work. So thank you for being here today. This is our executive steering committee. We're based at USC in the Office of Religious and Spiritual Life under the guidance of Dr. Dean Varun Soni. And these are all of our executive steering committee members. Thanks for attending, and please be on the lookout for future symposiums. And please feel free to sign up to our listserv so you can hear about our activities. All right, I'm going to stop sharing right now. And I'm going to invite in our first speaker. Dr. Sheridan's going to come speak first, I think. Dr. Mash, when she logs on. There we go. Terrific. So I'm going to pass the baton to you, Dr. Cherian, and I'm going to turn my camera off. So thank you both for being here today. And there we go. Perfect. Go ahead.
Okay, thank you very much. It is with profound sorrow that I am here on the heels of the devastating loss of Dr. Nolan Williams, and I want to thank the symposium organizers for their dedication of this event to Nolan, and also for giving me a few moments to speak about him. Our hearts are absolutely shattered for his wife, also a brilliant psychiatrist, Dr. Kirsten, and their beautiful children and their families. Nolan was a doctor and researcher of uncommon brilliance. His reach was global, not just among those who worked with him, those who learned from him, and those who were treated by him. The pain of his loss runs deep in all of us. Nolan's specialty was looking for novel and rapid ways to treat people who were struggling from neuropsychiatric disorders. He was a trailblazer. He first rose to prominence when he devised a new protocol of transcranial magnetic stimulation that is called SAINT. That's an acronym for Stanford Accelerated Intelligent Neuromodulation Treatment, and this personalized protocol provides the same amount of stimulation that was previously delivered over 6 weeks in 1 week. I met Nolan as he was starting his pilot project for SAINT. I was his first practicum student, and he let me add a cognitive battery to this study, and that served as the basis for my dissertation. He was on my dissertation committee, and to my knowledge, mine was the first dissertation on whose committee he sat. I have known and worked with Nolan since 2016. I got to see him with patients. I saw his gifts as a practitioner. He was compassionate and attentive, and so reassuring to his patients. SAINT has gone on to become FDA approved, and the number of times I hear that this protocol has help people regain their lives or even save their lives just keeps increasing. I joined Nolan for my postdoc starting in 2020, and he tapped me to lead the Ibogaine study. This treatment was like the other studies of treatments that Nolan was leading. We could literally see in front of our eyes people getting better. As mental health practitioners, what a gift it is to bear witness to people's recovery who have been suffering for so long. And not only did we see people get better, they got better rapidly. Usually by the third day of SAINT, there was visible change in many patients who reported alleviation of their mood symptoms, a return to a state that they had not experienced for years. For the Ibogaine study, I had the privilege of sitting with each and every one of the study participants. I conducted clinical interviews and neuropsychological testing with them prior to Ibogaine treatment, and then I saw them a week later after they had been treated about 4 days prior. I witnessed profound differences in these Special Forces veterans, people who had put their lives on the line for this country and who had been struggling with deep depression and post-traumatic stress in the setting of traumatic brain injury from exposure to multiple blasts. And frighteningly, some only after treatment shared with me that they had not admitted to experience suicidality, one of the most dangerous kinds of suicidality, when no matter who asks, no matter what kind of support there is, they will hold these cards close to their chest, not necessarily seeing that there are other paths they could take. These Special Forces veterans returned from the clinic in Mexico free of these burdens, and I could see it. I could feel it in the room. They were able to engage in life again. They were able to repair relationships with their families and their friends, and they were able to finally carry on. And as one participant put it, they could finally come home. Nolan, in his brilliance as a scientist and researcher, understood that we needed to investigate these treatments, that they were providing solutions to problems, and we really needed to learn how. And I want to add here that we were only able to be at this point because of the work of my esteemed colleagues on this panel who had already been paving the way. Since Nolan's passing, I have been hearing from some of the study participants who share their sorrow that Nolan saved their lives by providing for some a way to justify seeking treatment, if it meant doing good for others in the process, by being able to contribute to the science in something that was saving lives, that was reducing veteran suicide. This is the central tenet for Veterans Exploring Treatment Solutions. This is the nonprofit that has been working tirelessly to this effect and to change the laws in the United States to permit study of psychedelics in this country. Nolan was involved in these efforts as well. I remember him saying, "Let's change the world." Nolan was a visionary. He saw so much that many of us did not. His lab was incredibly busy and fast-paced, studies occurring at the same time for treatment-resistant depression, OCD, bipolar disorder, borderline personality disorder, cannabis use disorder, and traumatic brain injury, and suicidal ideation. So many people who trained with him are sharing myself included, stories of how Nolan saw potential in us that we did not see in ourselves. He gave us opportunities for growth that were at times anxiety provoking and uncomfortable, but we came out the other end better for it. This is interestingly similar to Ibogaine, how Ibogaine opens up new perspectives and solutions to what previously seemed like insurmountable problems. Nolan envisioned novel treatments and the potential to deliver these in groundbreaking timeframes to the patients most in need. He was able to see what the world needed, and he pushed hard for all of it. Nolan only had 42 years, and he did change the world. It will take time for us to process this loss, but I'm confident that we will do our utmost to honor his legacy and carry on his excellent work. And while doing so, let's be sure to take really good care of ourselves and each other. Thank you.
Thank you. That was beautiful. Dr. Mesh.
I'm here. If we can have my first slide, please. I'm grateful to the organizers for inviting me to present today, and listening to my colleague, I want with my whole heart and being to dedicate this in memory of Nolan. Next slide, please. Ibogaine today is a lead molecule that is being advanced in a novel series of next generation compounds, and it is also currently in use in unregulated settings throughout Mexico, the Caribbean, parts of Europe, and elsewhere. We identified an active metabolite of noribogaine, which is not an oniric molecule, not a psychedelic, which is also in clinical trials. And both ibogaine and noribogaine are advancing novel composition of matter series that are being tested in non-clinical as well as clinical trial studies. So this field has moved considerably. Next slide, please. But the history of Ibogaine really goes back more than 100 years ago, when some of the colleagues that are listening and on the panel you will hear from subsequently were part of an active movement. And it's important also to acknowledge that Ibogaine itself has over 100 years, 150 years of ethnobotany and ethnopharmacology. And in low-dose formulations, Ibogaine was sold in France as an elixir or a mild stimulant. So there was 20 years of the marketing of Ibogaine under the trade name Lambrine in the pharmacies in France. The seminal discovery of Ibogaine goes back to Howard Lutzow, where he made the initial discovery and repeated the sort of seminal experiment, if you will, not only with himself, but with a handful of people. And he was able to demonstrate in that initial experiment, personal experimentation, like many others who have done with psychedelic medicines, that Ibogaine was a very powerful addiction interrupter. And it was Howard Lutzow who taught me that term of art. Ibogaine is an addiction interrupter. In the 80s, Howard Lutzow went further and advanced towards the idea of a company to actually be able to develop it as a medicinal product. Unfortunately, he was unable to advance it with any kind of significant support. And nonetheless, because of the publicity and the knowledge and the open label testimonials from individuals who have sought Ibogaine treatments, there was pressure that came to bear on the National Institute on Drug Abuse And this is where my laboratory and my research group steps in, because we too had heard about this almost remarkable efficacy, rapid acting efficacy of Ibogaine. And I myself was curious. So when Howard Lutzoff contacted me, I asked to be able to see it with my own eyes. And we traveled to the Netherlands and saw patients being treated with Ibogaine in settings in Amsterdam. In 1993 and 1995, we went up in front of the FDA and were able to get FDA permission to advance Ibogaine. And in 1995, there was open discussions, convened meetings with the National Institute on Drug Abuse, but ultimately NIDA decided to sideline Ibogaine research and said no to any future funding. Because Howard Lutzoff had no funding, this basically brought Ibogaine research to a halt. Next slide, please. The FDA was very collaborative. And when we first went up in front of FDA in an open meeting in 1993, it was attended by many, many people. Howard Lutzoff was there. There were many people who had taken Ibogaine who were providing testimonials. And there were also other individuals presenting on behalf of NIDA on some animal studies with Ibogaine. But the meeting was very difficult because the NIDA-funded investigators who were under contract suggested that Ibogaine may cause cerebellar neurotoxicity. And if you want to halt Ibogaine research, the way to do it is to raise a neurotoxicity flag. Undeterred at that moment, I went into a closed door session. I closed the public hearing and we went into a closed door session. And with the guidance of people on the advisory committee, we were able to get permission to go into what we called at the time Ibogaine veterans. These are not veterans who have gone offshore to Mexico that we will hear about in Dr. Cherian's lecture, but these were people who had taken Ibogaine before and already had the risk of exposure to Ibogaine. This is what the FDA gave us permission to do. Unfortunately, there were some other things that happened at this time which slowed our clinical advancement at the University of Miami. And also it was difficult to find people who had taken Ibogaine and get them to be admitted under our protocol, FDA-approved protocol. So I went back to the FDA in 1995. In a closed-door meeting, I invited NIDA to come in the table with us as the sponsors, and the FDA allowed us to go up to 8 mg per kg hydrochloride, which would be the equivalent of 9 mg per kg free base of the drug, which we know today would be an oneric dose of the drug. Next slide, please. Because we were unable to fund the clinical trials, despite my best efforts, and we submitted grants to the NIH, and we also worked closely with the National Institute on Drug Abuse. As I explained, NIDA decided to take a pass on funding or in advancing this work. The University of Miami allowed us to go offshore, and we established the first psychedelic clinic anywhere in the world, to my best knowledge, which was the Healing Visions Institute for Addiction and Recovery on the island of St. Kitts in the West Indies. The prime minister of that country, himself a medical doctor, gave us government permission, and we brought our teams of investigators and collaborators down to St. Kitts. And in the course of this work and working with other investigators at Pfizer and the University of Toronto, the University of Southern California, and elsewhere, we demonstrated that Ibogaine has complex pharmacokinetics, gets converted to this active metabolite, nor-ibogaine. And as you can see on the right-hand side, Ibogaine in dark blue is rapidly cleared from the blood under 24 hours, but there is this long-lasting metabolite, which has a half-life on the order of 24 to 30 hours. So it takes, 5 to 6 half-lives to clear. So in the days after Ibogaine, patients have high concentrations of nor-ibogaine in their blood. And we speculated at the time that noribogaine may mediate some of the beneficial after effects of Ibogaine. Ibogaine has, as I said, complex pharmacokinetics going through a genetically regulated enzyme in the liver, cytochrome P450, 2D6. Many other CNS active drugs also go through this pathway. Next slide, please. In 2018, after years of doing research in the Caribbean, I published this paper in Frontiers in Pharmacology, and I'm not going to provide further information on these studies, but it is one of the largest case series, open label case series that are published in the medical literature. But next slide, please. And this just gives a summary of the number of subjects. We actually have, to my knowledge, again, the largest safety database of audited charts and with MEDRA coding from a total of 276 patients in St. Kitts. And as you can see on the slide, the majority of these patients were Caucasian. They had considerable education, primarily the opioid use disorder, but also cocaine use disorder were the largest represented group in this case series. Next slide, please. But in 2018, there were also, besides our publication, there were also a series of other publications, and these are summarized in a review article that I published in 2023 in Pharmacology Research, which was an invited publication submission from the IUFAR group. And basically what you see are the numbers of subjects in these different studies. The problem with this, although this does provide a safety database for regulatory filing, the study designs, dose range, and purity of the drug product remains a deficiency across these studies because they weren't matched. The inclusion cohorts are not matched. Most of these data sets are not audited, and it provides information and supporting an important open label efficacy information. But as you'll hear in subsequent slides, it may be insufficient to help us move to phase 2 in future FDA studies. Next slide, please. So to summarize the real world evidence, today we estimate that there's over 20,000 people who have gone outside to take Ibogaine in countries where the drug is unregulated. If you add up all of the publications, including the 287 patients from the St. Kitts cohort, we estimate in our investigator brochures that there's about 648 patients that have been reported on in the literature, in the peer-reviewed literature. They're very consistent efficacy across these open label reports of withdrawal, reduction of withdrawals, reduced cravings, self-reported abstinence for weeks, months, and sometimes years, and reduced comorbidity of depression and anxiety. However, there are also reports of relevant safety issues, which are transient QT interval prolongation, the cerebellar ataxia, which is, again, transient and normalizes as Ibogaine clears from the bloodstream. But unfortunately, because people have taken Ibogaine in unsafe settings, we also have deaths that have been reported, and this has been a real setback for many of us who have tried to advance Ibogaine with funding from the NIH and other foundations, and also in front of the regulatory agencies who provide authorization for GCP clinical trials. Next slide, please. In Kentucky, when Kentucky was the first state to actually push ahead with the idea of providing funding from the opioid abatement settlement, this flyer, I've recreated the flyer, but this was a flyer that was put out by the NIH HEAL initiative, which basically was telling people that Ibogaine, although there was this open label efficacy data, that it's basically anecdote, and that the plural of anecdote are not data. So the idea here was that Ibogaine is a Schedule I drug. It has no accepted medical use, and it has a high potential for abuse. Those on this lecture know that Ibogaine is not an abuse drug. In fact, just the opposite. But it has shown efficacy. They agreed that it shows efficacy for opioid withdrawal. But the fact is that despite this, the deaths that have been reported and the severe adverse events, and including life-threatening heart problems, really make this a non-starter. Next slide. But it was this publication, which we will hear about in great details after my presentation, which really opened the door, which really changed the field. It was this publication that gave wings to the Ibogaine movement and led to the important initiative in Texas. Next slide, please. Which was groundbreaking, a first, an important change because it brought in the data. It moved it in a way that let people in government, people in both on Capitol Hill, as well as in the great state of Texas and elsewhere, the courage to say that we need to test this drug in a controlled environment with safety and with clinicians who are well qualified and skilled. It's too important what we've been doing in this country to address the problems, not only of veteran suicidality, but also of the ever-growing epidemic of drug and alcohol dependence and the cost to our society, that we need to advance this drug with competent clinicians and have a Manhattan-style project and bring all players who are interested in learning about this drug, all hands on deck. Next slide. And like Texas, other states have joined into this, including Arizona, which has put up $5 million to open a clinical study in their state. Colorado regulators are considering it. We know that it's occurring elsewhere, and I won't summarize all of this right now. There are some discussions in Oregon and elsewhere. But some exciting things on the Hill include our new FDA director, who is willing to discuss psychedelics and thoughts about clinical trial reform and how you deal with the issue of unblinding, working with these classes of molecules. So there is some hope that finally we can begin to get into the clinic and do these studies. Next slide. So is there a regulatory path forward for Ibogaine? Well, as I mentioned to you, in 1993 and 1995, the answer was yes. And I repeated this communication, this type of request from the regulators to consider. And in the UK, we were able to provide our safety database and our information from our investigator brochure and other supporting information to them, and our CMC, our chemistry, manufacturing and control package with for GMP drug product. Very important to get in front of the regulators. You need to have a GMP drug product, not always for phase 1, but indeed it's helpful if you do so. And we were able to get permission to go forward with a phase 1 study to really map out dose-related QT prolongation. For a phase 2 study, a proof of concept study. It will be our hope that that will go forward in Texas. And I believe there are 2 applications now that are being considered in Texas. I don't know if there are others, but my understanding, without much transparency on the process at this point in time, that there are 2 applications that are being reviewed now for that funding. And the idea will be to advance a phase 2 trial to determine the efficacy of Ibogaine in the intended treatment population. The intended treatment population, in this case, based on the bill that was signed into law, would be opioid use disorder, but of course, PTSD or PTSD comorbid with opioid use disorder may also be one of the indications. How do we get to, what is the size of the phase 2 will be determined in discussions with the regulatory agencies. And of course, there is a risk that the regulatory agency, at least with the FDA, that they may require the phase 1 studies to be completed to really anchor this issue of QT prolongation. We do not know whether they'll allow the groups to go directly into a phase 2 study. Phase 3 clinical trials can take many years and $100 million to complete. However, if the phase 2 trial demonstrates what we believe it will, and that the drug can be administered safely, which I believe it can, then there is the possibility to allow expanded access to the drug. And that, of course, could accelerate the pace of the phase 3 trial. And as I sit here today, I recognize that post-approval studies will be needed. And of course, Ibogaine, if it gets to an approval, will be done under a REMS. Next slide. So the question for the regulators is going to be, do the benefits, do we have the data to demonstrate that the benefit, do the trials demonstrate the benefits outweigh the risks? And today we have medicines that are approved for acute withdrawal management. We have methadone and lofexidine, which are approved in the United States, and we have off-label use of clonidine and buprenorphine taper to control acute withdrawal. But what we don't have is successful withdrawal that addresses the protracted negative affect. And it's the protracted negative affect, as I have written in my work and publications, what I believe is what causes the relapse and why success rates following withdrawal management are so bad, why they're not good outcomes. And so demonstrating, will Ibogaine demonstrate an extended window of relapse prevention? And that is one of the outcome measures that I believe will be most important in demonstrating that the benefits outweigh the risks. Next slide, please. The primary risk of the drug, as I mentioned, is drug-related QT prolongation. And if you're interested in this, there is an article, just recent article from Kirsten Garnett, who was one of the leads at FDA on this whole topic of QT prolongation. We know that Ibogaine is a QT prolonging drug. It is a hERG channel blocker, nor Ibogaine lower affinity for hERG, and also will block the hERG and contribute to hERG blockade with Ibogaine, so they're additive on hERG. These need to be discussed and anchored. We need to understand the magnitude of the QTC prolongation, its time course by genotype. And again, how do you risk mitigate? Well, you risk mitigate it by looking at electrolytes like magnesium and potassium, and also making sure that you screen for underlying cardiac risk factors that may be genetic or otherwise. And so this can be done, and it can be done very well. And we did it in our trials, and we can share best practices with others. Next slide, please. However, work published by the Dutch group suggests that Ibogaine is unsafe and should not be studied because in their work, the magnitude of the QT went over 500 milliseconds, and 500 milliseconds, again, will be a regulatory non-starter because that is extreme risk for a condition of a fatal arrhythmia called torsade. I and my colleagues wrote a review to the Kenneth paper because the Kenneth paper was, in fact, never designed that study that was registered, not a GCP trial, but a registered study from the Netherlands, was not designed to answer this question. The drug product that they used was probably off stability and out of date, and there are a number of other issues with the study. And if you're interested, you can read my reply to Kenneth and his own work. The important thing is that there were no deaths in his study, but he suggested that 7 out of 14 of the people dosed in his study went up over 500 milliseconds. This is a problem because people like Dr. Mark Hagney, who himself wants to kind of convince the world. He did so in Kentucky and he's done it elsewhere, and he will continue to be an ardent spokesperson against Ibogaine development, suggests that the QT prolongation hits a critical threshold and the drug is simply unsafe. Working with one of the lead cardiologists in the world, world-renowned Dr. Merrick Malik, we have done work and we have some ideas that we will share with our colleagues in Texas about the nature of the QT prolongation and what can be inferred from proper clinical trial design. And I believe we can get over this hurdle. Next slide. I only have a few slides left. So how to avoid a clinical hold following an IND submission is very important for our colleagues in Texas. We need to assess risk factors in the trial participants. We have to have patient monitoring. We have to communicate with the FDA. We have to tell them everything we know. They will be collaborative. I believe that wholeheartedly, that FDA will be collaborative. And we need to provide the data on drug and metabolite effects on the QT interval. We have those data, and we also have data on pro-arrhythmia studies that were conducted in vitro and also non-clinical telemetry studies in animal models like primates. The data are available. Next slide. Opioid use disorders and acquired disease. We recognize that there are other medications that are currently approved for use, but they continue a patient's dependence on opioids. Ibogaine may prove to be, as Howard Lutzoff said, an effective addiction interrupter because the oniric psychedelic effects help to prepare patients for what we heard Dr. Cherian say, the radical transformative changes in behavior. Pre-contemplative, contemplative, ready for change. I like to say that. Next slide, please. The medicines that are approved for use do not promote lasting disease-modifying changes. This fact may explain why there's a lack of adherence and high relapse rates. Next slide, please. Herb Kleber, who passed away, who was the drug czar, was medical director, advisor to the drug czar, Dr. Bill Bennett, Dr. Kleber to William Bennett, who was the drug czar at ONDCP. He explained when he reviewed methadone maintenance 4 decades later that people need to stay on methadone, or what we would say today, what ASAM would say today, they need to stay on buprenorphine because of the increased risk of relapse once medication is discontinued. Ultimately, he said the problem of interminable maintenance versus relapse may require learning how to reverse the brain changes associated with addiction. Next slide. And that is Ibogaine. Ibogaine may be, as Dr. Williams and his team demonstrated, a profoundly transformative drug because it promotes neuroplasticity in the brain, and it brings about these rapid-acting antidepressant mechanisms of action, and it can be targeted for treatment with follow-on med and adjunctive therapy of naltrexone or perhaps Ibogaine in the future, if Ibogaine advances in clinical trials. Next slide, please. And in this way, when we get to the point where we are able to open that IND, when that IND opens in Texas, it will be the greatest honor in memory of Dr. Nolan Williams and his team. And I can tell you, as I sit here today and speaking with you, that I deeply mourn him. I deeply mourn him because it was his research that let me feel like my work with the molecule had meaning and purpose and was not in vain. And so I acknowledge him, and I send my love to his family, his children, and to his laboratory, and to all the colleagues, all his colleagues, who acknowledge his great gifts that he gave all of us in the field of Ibogaine research. Thank you.
Thank you, Dr. Mesh.
Thank you very much for having me. And Dr. Mesh, thank you very much for your words. So I am here to talk to you about the magnesium Ibogaine therapy study in Special Forces veterans with traumatic brain injuries. I have no financial or non-financial conflicts to disclose. So combat-related TBI, or traumatic brain injury, is the signature injury of the Iraq and Afghanistan conflicts. These injuries are mainly from blast exposures. Almost half of the veterans returning, or almost half of the military members returning, screened positive for traumatic brain injury. Special Forces veterans are at increased risk of traumatic brain injury compared to conventional military, roughly 22% higher prevalence in that group. And it's really important to note that traumatic brain injury is highly comorbid with post-traumatic stress disorder. Next slide, please. So post-traumatic stress disorder is one possible sequelae of combat-related traumatic brain injury. The rate of post-traumatic stress disorder is almost double in Special Forces veterans compared to conventional military. There are functional impairments that are associated with both traumatic brain injury and post-traumatic stress disorder. In our group, what I would see was people who would arrive who had not been able to work, who had trouble even leaving home because everywhere was a trigger for them and they had trouble regulating the emotional reactions and responses. I saw people on the verge of failed marriages. I saw people who were having a lot of trouble within their own families, people who were socially isolated because they had trouble getting along with other people, trusting others. People who are dealing with executive function problems, not being able to figure out solutions to problems that they would otherwise have been able to do quite easily. Suicide is also a problem associated with traumatic brain injury. It's currently at the highest rate for veterans in recorded history. Since 9/11, more than four times as many military members have died by suicide than those that died in war. Special Operations Forces have the highest rates of death by suicide compared to both conventional military and the general population. Chris Frew and his group identified a constellation of symptoms that he coined operator syndrome. And this is something that is present in many special operators, kind of those who have been exposed to a lot of blasts and a lot of combat, and veterans. This constellation of symptoms includes chronic pain, endocrine dysfunction, disrupted sleep, substance use disorders, cognitive impairments, interpersonal problems, mood disorders, reactivity, anger, and existential problems, difficulty adjusting to civilian life. And next slide, please. There are cumulative effects that can be seen on neuroimaging of even low-level blasts, including biomarkers of neuroinflammation, changes in cortical thickness, reduced white matter integrity, and reductions in structural volumes. These biomarkers can indicate an increased risk of development of later neurodegenerative disorders, particularly in the setting of PTSD and unmanaged depression. Special forces veterans are at increased risk of neurodegenerative disorders because later neurodegenerative disorder after having sustained a traumatic brain injury is up to 2 times higher than those who have not. Next slide, please. Thank you. So we're looking at a problem of treatment efficacy. When you look at this comorbidity of traumatic brain injury on exposure to multiple blasts, and I'm talking hundreds of blasts. And we also have post-traumatic stress disorder. We also have depression. We also have anxiety. We also have substance use disorders. So all of those things together, we're trying to treat using conventional treatments. And in the best of times, PTSD remission rates using conventional first-line therapies are low. Remission rates with oral antidepressants are even lower. When you look at treatment of depression, conventional therapies and oral antidepressant do not provide satisfactory remission rates, up to 30% almost. For traumatic brain injury, there is no one medicine that can resolve these symptoms. Within the special forces community, there is also deep concern about career and stigma, also mistrust. One operator told me they look for vulnerabilities in other people. They are unwilling to reveal vulnerabilities within themselves. So this creates a barrier to help seeking. And some have an inability to afford private care, and some just won't. Research is needed to explore alternative treatment options that address the complexities of these military traumas. Next slide, please. So what has been happening is there are special forces veterans that have been crossing the border and seeking treatment outside of the USA with Ibogaine. And what is Ibogaine? As we learned some of this from Dr. Mash, Ibogaine is an alkaloid that is derived from the root bark of the Tabernanthe iboga shrub or other related plants that are native to Central Africa or the west coast of Central Africa. There's traditional or sacramental use by the Bwiti religion. And the majority of studies prior to this study have explored its anti-addictive properties. And as Dr. Mash said, it does have that addiction interruption aspect to it. It's currently a Schedule I drug in the United States. So this is where the laws are really going to be helpful at the current changes. Ibogaine and its main metabolite, noribogaine, act across multiple neurotransmitter systems. So that includes NMDA, glutamate, serotonergic, dopaminergic, and so on. Ibogaine can also upregulate the transcription of neurotrophic factors. So brain-derived neurotrophic factor, that's what BDNF stands for, and GDNF is glial-derived neurotrophic factors. These are substances that can help the brain to repair. And Ibogaine also appears to facilitate a state of neuroplasticity. Next slide. A study done by Nolan's group when she was at Johns Hopkins gave us some insight into the mechanism of how this neuroplasticity arises. And if you go to the next slide, you can see that there were some rodent studies that showed that there were some durable effects to reopening critical periods. And these critical periods are periods of increased neuroplasticity. And the length of time, the bottom chart, shows the length of time of this increased neuroplastic state. And the length of time of these neuroplastic states was proportional to the length of time of acute effects in humans of these medicines. So we can see that there is we can kind of extrapolate that there may be these windows of increased opportunity of neuroplasticity following the use of psychedelics. Next slide, please. So some of the risks, Dr. Mash has already talked about neurotoxicity, like mostly a transient ataxic effect. Seizures are rare, thought to be related to high doses. The cardiotoxicity that Dr. Mash talked about related to QT prolongation, and other risks include drug-drug interactions. So there's some risk mitigation strategies that have been used, and those include thorough pre-screening of people who are seeking treatment with Ibogaine, vital sign monitoring during treatment, taking steps to ensure no toxic drug-drug interactions will occur, and co-administration with magnesium as a cardioprotective agent. Next slide, please. So this study was published in January 2024, and we were able to share the results of our study that I'll just kind of run over with you quickly. Next slide, please. We saw 30 Special Forces veterans. I screened 34 and enrolled 30 into our study. And we got veteran referred to our study from vets. This is Veterans Exploring Treatment Solutions. And they have been very important in raising treatment grants for Special Forces veterans who are seeking to pursue Ibogaine treatment and other psychedelic treatments, and other treatments as well. They also have been really integral in trying to get the laws opened up in this country to allow for research to happen here. So our pipeline of participants was really through vets, because we were conducting this study that was observational in nature. People who had already been seeking Ibogaine treatment and who had already scheduled themselves and then agreed to permit us to follow them. So next slide. At baseline, they would come to Stanford first, and there we would do clinical assessments. So I would do clinical interviews, and they would complete questionnaires, and I would assess them for post-traumatic stress disorder, depression, anxiety. I would administer a neuropsychological test battery. They would attend for MRIs and EEGs. Then they would go to Mexico for treatment at the Ambio Clinic. And the treatment, so they would come to Stanford and be seen on Saturday, Sunday, go to Mexico on Monday, and Ibogaine was administered on Tuesday. Then they would return to us to be seen again on Saturday and Sunday, immediately following the treatment, where we did the clinical evaluation all over again, the neuropsych testing all over again, and the MRI and EEG as well. And we repeated this at 1 month post as well. Next slide, please. So the primary outcome measure was disability. So based on a self-report scale, we used the WHODAS, the World Health Organization Disability Assessment Scale. And at 1 month post treatment, there was an 88% reduction in symptoms following treatment. And at 1 month post, there was an 86% remission rate following treatment, where the vast majority, you see a dashed line, it's a black dashed line down the center of this graph, and that represents the average response. So people were essentially the average response was no disability following Ibogaine treatment at 1 month post-treatment. Next slide, please. I also did clinician-administered assessments of post-traumatic stress disorder symptoms, depressive symptoms, and anxiety symptoms. After 1 month, there was an 87% reduction in post-traumatic stress disorder symptoms, and an 83% remission rate. After 1 month, there was an 87% reduction in depressive symptoms and an 83% remission rate. And after 1 month, there was an 81% reduction in anxiety symptoms and again, an 83% remission rate. Effect sizes of treatment were all above 2 for disability, PTSD, depression, anxiety. That's Cohen's D2, so it's a very strong effect size. We also conducted neuropsychological testing, which showed significant improvements in processing speed, which is on the top right of that graph. And then along the bottom, we had significant improvements in cognitive inhibition, cognitive flexibility, letter fluency, working memory, and problem solving. And so those all represent executive functioning. And all of these significant findings did survive multiple comparisons. We also did neuroimaging. As I said, participants would attend for a functional neuroimaging scan, and which we did at baseline, immediately post-treatment, and 1 month post-treatment. The scan included a structural MRI, arterial spin labeling, and functional magnetic resonance imaging, and we used a multimodal whole brain analysis approach to examine changes. Traumatic brain injury has been shown to lead to increased MRI predicted brain age. So there's an algorithm where you can predict somebody's brain age with an MRI. After 1 month of Ibogaine treatment, another piece of our study was published showing electrophysiological changes in the brain. And this showed that after treatment, there were the slower oscillations in the theta and alpha range were at increased power, and the higher frequency beta gamma ranges had decreased power. And these neurophysiological biomarkers correlated with improved executive function, post-traumatic stress disorder symptoms, and anxiety following Ibogaine. Altogether, these findings suggest that there is reduced spatiotemporal complexity of brain activity and slowing of cortical oscillations in the brain at rest after magnesium Ibogaine therapy, which may relate to psychiatric and cognitive impairments after Ibogaine. And next slide, please. So benefits from Ibogaine as identified in this study. Ibogaine demonstrated remarkable therapeutic efficacy for overall disability, post-traumatic stress disorder, depression, anxiety symptoms, and cognitive symptoms that persisted for at least 1 month without noted safety concerns. Remission rates for PTSD, depression, and anxiety 1 month following treatment was 83%, and cognitive functioning improved, and a measure of functioning over multiple domains of life revealed profound improvement. Analyses of long-term follow-up suggest the durability of these improvements is strong out to a year post-treatment. We have seen morphometric brain changes on the 1 month MRI scans, including increased cortical thickness and reduced brain age. Changes in electrophysiological biomarkers were seen on EEG that correlated with improved executive function, PTSD, and anxiety. Next slide, please. Risks, echoing Dr. Mash, there are some risks, and the neurological symptoms that were seen in our study were as expected during Ibogaine administration, transient ataxia that cleared. Cardiac risk was mitigated with careful pre-screening, taking steps to avoid drug-drug interactions. And what this essentially means is people who go to clinics are advised not to be on other medications that could provide harmful drug-drug interactions, and any medications they're taking that are safe to take must be given over to the clinic staff for administration so that the clinic staff knows exactly what they're taking. There's cardiac monitoring and vital sign monitoring during treatment and co-administration of Ibogaine with the cardioprotective magnesium. In our study, there were no symptoms worsened beyond baseline, even in those whose symptoms did not continue to remit. There were no unanticipated effects of Ibogaine seen, and there were no cardiotoxic effects in this group that was carefully screened. So there were some limitations of our study. This was not a randomized controlled trial. This was an observational study, and the participants were self-selected to go down for Ibogaine treatment. There may have been a potential expectancy bias. Within the Navy SEALs veteran group, there does seem to be a lot of discussion. This really helped me. Maybe it'll help you. So things like this can lead to expectancy bias. We didn't have any controls, so we can't parse out potential contributions from complementary treatments, from coaching, from effective international travel to a beautiful location, for group interactions. The majority of TBIs and functional disabilities in our group were mild at baseline. So it would be important to redo a study where the disabilities and TBIs were at a higher level. There may be some practice effects on neuropsychological testing. We did our best to mitigate for this by using alternate forms and trying to use tests that were a little bit more resistant to learning effects. Our sample size was also small and not diverse. So our results are not generalizable beyond the special operations veteran community, mostly white males in excellent physical condition. We did not specifically address suicidality outside of a depression measure, and it would be necessary to further understand effects on suicidal ideation by using a different measure of suicidal ideation. So future directions will be to establish efficacy of Ibogaine treatment relative to placebo, if we can, in a larger randomized controlled trial with greater participant diversity, and to conduct longer-term follow-ups that include clinical, cognitive, functional, and physical outcomes, and ongoing imaging. This is our team, led by Nolan. And next study acknowledgements again for more people within our brainstem lab. We were funded by private philanthropy, and special thanks goes to the treatment clinic in Mexico, Ambio Life Sciences. Special thanks to Veterans Exploring Treatment Solutions for facilitating recruitment. And most of all, biggest thanks to the participants who were veterans in dealing with a lot of very difficult ongoing challenges. And they gave so generously of their time while dealing with these challenges and allowed us to follow their healing journeys. Thank you.
Thank you so much. What a wonderful presentation. Very thought-provoking. I'm going to invite Charlie and others to come back online with their video. There we go. Dr. Ken Alper and Dr. Deborah Mash and Dr. Charlie Kaplan. So I will pass it over, Dr. Kaplan.
Wow, that's all I could say. Two fantastic presentations, and I know there will be some great questions. So we only have about 17 minutes left, and the first thing was to just kind of Ken and I to chat a little bit about what we thought of the presentations, and then opening it up for questions to Dr. Mash and Cherian on their presentations, or just questions about Ibogaine in general. So Ken, this really represents a milestone, don't you think?
I think Dr. Alper's having connectivity issues, Charlie,
Oh,
so
okay. Oh, okay. Well, then I'll just chat with myself, but and give you my impressions until he gets back online. Well, like I said in my opening, I felt that this is a what would call an auspicious moment in history. I mean, and it's uh, where the past and the present come together very, 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 very profoundly and significantly, giving us a view of what the reality of Ibogaine is. And it is a very complex reality, as we have seen. I know Ken and I were involved more or less from the beginning. And my institute in Rotterdam at the time was founded on a principle of ethnopharmacology. So I was the ethno part of it, and Dr. Jolik was our pharmacy. Dr. Jolik did the first experiments with mice and the interruption. Uh, and you know, we had a very democratic organization where the pharmacist and the, let's call it the ethnographers or the social uh, uh, or the the people, because our program was built on a Dutch medical principle of the time that if addiction was a disease, then uh, the government should support patients groups that are advocates for better treatment for addiction. And that was passed. And our our group, especially the ethnography group, uh, formed an alliance with the Rotterdam Junkie Union to do the ethnography, to look at the rituals that people used to sustain and to reinforce their uh, opioid addiction. And that was our part of it. And Dr. Jolik's lab was to look with animal models rather than human models. However, since we were so democratic and so closely uh, uh, tied, we um, the word got out about what was going on in the lab, and uh, and and the uh, community field workers, which then was hired in from the Junkie Bund, uh, heard about it as well as I did, and and that's where it it moved outside the normal traditional uh, medical pipeline into uh, what what Ken and I published in 2006 called a medical subculture. A subculture quickly developed around Ibogaine, and that is primarily what I've been interested in for most of my time with Ibogaine. And
That's where
uh,
we are today.
what?
It's where we are today.
Yeah,
As we're doing a fireside chat, I mean, we're the gray zone of unregulated use is exactly where we are today.
yeah.
So how do we get out of the gray zone?
Well, I think we are getting out of it, and again, an appeal to democracy in a very paradoxical way. Uh, um, the people decide, and that's what happened in our unit. The the junkie union was supported by they got their funds managed by a social worker to advocate for better treatment and reform. And they that empowered them, and they took it into their own hands, so to speak, and obtained Ibogaine, and then started to try it, among themselves, and were immediately, like we've known now from history, from all of the work that we've just heard, profound and dramatic effects that they felt. But
in a vast underground experiment.
in a vast underground experiment.
I think Dr. Alper is back too.
Yeah, Deborah, don't you feel fundamentally more optimistic that this, weight of evidence, we've all in our tried to mine the vast uncontrolled experiment for data. And it would seem that, what's going in Texas, and, that there's these, initiatives to do, for phase 2 studies. What's your feeling about that overall?
Now, not to be a negative Nancy, I'm very concerned. And I think as I tried to make clear in my presentation, it's precisely the seminal work from the Stanford group and spearheaded by Dr. Williams that gave us a bright light. And the importance of continuing his legacy studies, and with his collaborators and leadership as from Dr. Cherian and others in the group, to really demonstrate, again, as I said, the benefits outweigh the risks. And I think that there will be, my sense, because it's been my experience over decades. How many years have I been doing this, Ken? 30 plus years.
More than 30.
Yeah, thank you for aging on the Zoom. Everybody knows. But yeah, is that their work, is, again, Dr. Cherian mentioned limitations of the study. However, the neuroimaging data combined with the 12-month follow-up data, combined with the neuropsych assessments, the comprehensive battery of tests, and rapid, and not only rapid acting, but sustained demonstration of benefits over a lengthy time period, quality of life assessments, that has got to get in front of the mind of the payers, because ultimately this will be decided by the payers. People who can afford to go take Ibogaine, as she stated, in a beautiful place, will continue to go. But, we have underserved groups of people in our country who desperately need to have access to something like this. We have, whether we have trauma from blast injuries and multiple deployments, or we have, women that have been in the sex trade who have, poverty to, sex trade, who have deep wounded traumas, who then find, relief in drugs and alcohol. I mean, we can expand this. Am I optimistic? Today, the world is a little darker for me personally without Nolan, and I feel less safe without him in my world today, I'll be honest. And, I think that there will be, I'm fearful that there will be a pushback of the Mark Haney's of the world, who will, try to push us down. And I think also, if when I do these lectures in front of, groups with the American Association of Addiction Psychiatry or ASAM, whatever, people don't really want to take people off of opioids. It's that slide that I gave with, my beloved Herb Kleber, who told me, by the way, don't work on Ibogaine, Deborah, it's going to ruin your career. He warned me, don't do it. You're gonna have a good career, Deborah. You're, a young faculty member, you're on a trajectory, tenure track. don't work on Ibogaine. So I always had, I hedged my bets with multiple, funded programs because I couldn't get the funding for Ibogaine. I want this to go forward, Ken, and your publications in the field have shed great light on the issues and the opportunity. I've tried to do the same, and we need more data. I mean, data will trump the whole thing. And I do think what Charlie said about the patients, that the patients and the families, just like the power of the veteran movement has really pushed this forward, that we have to keep our eye on the bullseye. And the other thing is that I think that all of us, that we have a responsibility, a social moral responsibility to ensure that these studies go forward with high ethics, with the best ethics, and in the front here concerning the patient populations. And hopefully people like Sergey Brin Foundation and others that will put the dollars behind this, because that was my problem. I couldn't go anywhere because nobody would have funded addiction science.
Yeah.
It just didn't happen. So while I want this, I didn't give
Yeah.
up. I didn't give up. Why didn't I give up? I didn't give up because of the beautiful words that Dr. Cherian said. Seeing is believing. She saw the transformation. So did I. And so did you. And so did Charlie and others that, had the privilege and the honor to be part of the Ibogaine movement. Yeah. But I'm worried because I think, as the light gets lighter, the dark side gets darker. And I think there will be some forces that will come against us.
Well,
Next, next we have a question in the chat.
Yeah,
What type of study would help move the field forward at this point, and or that could be in reach considering the current landscape?
Dr. Cherian, come on. Join us.
Yeah, well, I think definitely further studies are required. I think we need maybe more preclinical studies, and so I think I would just love to see more of this coming forward. But you had it all kind of laid out there, Dr. Mash. All that needs to happen, and we do need to find funding for these studies. And so with these laws that are changing in different states that are opening up doors for studying psychedelics, I am a baby in this field. I'm not a baby, but I'm a baby in this field. And so I feel a little bit optimistic about that there are some avenues that are now starting to open up. So I'd love to see some more preclinical work leading into more clinical trials, looking at studies of different levels of dosing of Ibogaine. So those are some of the things that I'm thinking of.
That one of the fundamental, I think, but basically I would say your neuroimaging data, your EEG data, and your neuropsych,
Yeah.
Your seeing is believing. And when you can demonstrate on a brain scan, this is your brain after Ibogaine, and you can see, and you have functional correlates of structural changes, and you have longevity and enduring effects. This is huge. And the question is, if we can expand that in a larger GCP trial, well-funded, well-designed GCP trial. Of course, the challenge here is going to be the blinding. How are we going to blind this? But I do have some optimism. Maybe I'm an N of one, that the FDA today will be collaborative and helpful. And my personal experience with the FDA is that they've always been collaborative and helpful. And I've been up in front of them multiple times. You would think they would tell me to get out, but they don't. They welcome me back, and they help, and we get very instructive advice meetings, and their type B and type D meetings are very helpful. So I think the sooner we can get in front of them and have a thoughtful discussion with them, where any academic laboratory or Texas group or whoever, gets in front of them first will kind of set the tone. I do think that, I'm old, so I'm going to say this. I'm done with reverse translation to animals. We already have data in humans. This thing needs to go fast in people. All right. The safety studies in the animals, we're single dose administration. We're not looking at repeat dose toxicity. By the way, we have data on some of that, and there is some of that that was done by NIDA that we can reference, that we can put up into these IND submissions. I'm all for recognizing the public benefit of this now and getting as much of these data out there to support any and all qualified investigative groups that are moving the needle on this project. And that's what I think we need to do. That's what we need to do, because the sooner we get past the phase 2 and we can, get into phase 3, get the money and get into phase 3, we can do expanded access right here in the United States.
Yeah, yeah. We have to. I mean, we have an opioid epidemic it's gone down a little, but not significantly. Plus,
No, it has not gone down.
Yeah.
And it's because it's not dealing with the underlying acquired disease of addiction.
That's right. That's right.
I got to ask with Charlie here, who's an expert in qualitative methods, and then we have two presenters who've been in contact with lots of people. Deborah used to tell me the last conversation we had in Kentucky, you were telling me about the mothers that always contact you. What is the in terms of a qualitative study of the testimony of people who have lived with the significant others, the people who are, related to the people who have been treated with Ibogaine, what's the collective data that we have?
Well, there are a number of qualitative studies out there that have occurred over the years, but we need, as Dr. Cherian mentioned, we need a lot more preclinical work that parallels and supports and is fed into the pipeline that Dr. Mash has presented, so we could get over the hump because these preclinical studies might not have much effect on the medical established procedures, but we all know, and for many, many years, how slow that process is, and the problems get worse and worse. So how can we speed it up? Well, one way is that if we can't do these very expensive clinical trials, if we can get the mothers' voices, like what I did parallel was with my students, focus groups with patients who had experienced this. And a lot of what we found, which was presented at the NYU Ibogaine conference in the 1990s, was testimonies of reaching a state of wellness, which was exactly what Dr. Cherian described was going on with these veterans, that they have been sick for a long, long time. They couldn't talk. They were isolated. And they had to talk. And the focus group allowed them to talk. This wasn't a therapy, but was to provide testimony that this is evidence. Now, as a qualitative researcher, I think numbers are fine and all these things are fine, but as an ethnographer, I say science might have and scientists might have the best knowledge, unrefutedly, but the most knowledge about addiction or post-traumatic stress is not with the scientific knowledge, but the common sense knowledge of the people who have gone through this experience, the life experience.
Yeah, I would agree with you. What's moved it forward in Texas and Kentucky is, largely originated with the community of veterans
Yeah.
themselves. Kirsten, have you done any like systematic interviewing of family members and significant others of people who are treated?
I have,
Kirsten?
yeah, can you hear me?
Yeah, I can hear you now.
Yeah, okay. I have spoken to some family members just in the process of the study, doing my work. Some of the veterans would present with spouses, with children at the time. And I did hear from some family members, and they did note amazing differences in, following treatment. It was differences that, allowed families to regroup again and to repair ruptured relationships. Some veterans were able to repair their marriages. Some veterans were able to actually leave home and seek work and be able to reliably do so. So these kinds of things that we're seeing from this treatment is astounding. And again, it's like treating multiple things at once with such incredible efficacy. And I agree, with Dr. Mash. We have a lot of studies out there that are showing very similar things. And I think some of these studies going forward, we need to continue to collect these kind of pieces of data that all end up pointing in the same direction. The imaging data, the
Indeed.
EEG data,
Yeah.
the neuropsych data, the clinician administered measures, and so on.
I'm going to have to
Well,
interrupt.
it's sort of a glass is half full point. It seems to me that the other side has kind of changed their messaging, because now the messaging is that they're admitting that Ibogaine is effective, but now they're saying, well, this is just a boutique, method because it's expensive and it's not affordable. So they've moved from it being, questioning whether it works or not, to accepting the premise that it works, but now just saying it can't be scaled economically.
We're going to have to pause
That's
on this
progress.
comment. Yeah, we're going to have to pause on this comment because we already lost Dr. Mash. So I want to thank everybody for coming to this symposium, for those of you still online, and for your presentations and the work that you've done. I think capitalizing on where we find Ibogaine being sort of allowed into states is going to be a location where we can start to do some of these clinical trials that you're addressing. And that's going to just be sort of stepwise, little by little. I think that's one of the issues we're going to be facing about randomized control trials and of such. So, but I want to thank you, honestly, for coming and presenting and moderating and being here today to discuss this topic, as important as it is, and for honoring Dr. Nolan Williams today. I think everybody really had him in their hearts today and appreciate us all showing up, and Dr. Mash, who had to leave our call. But thank you everybody for attending. We're going to close out the session right now because we're at time and people are dropping, and I know people have other appointments to keep. But thank you so much for this wonderful, illuminating discussion, great data, evidence, and we have a lot of a lot of movement to go forward in an area that people feel very strongly about, and confident that it can be very helpful for treating patients. That's what drives all of us, is treating the patients and getting them to a state of well-being. So thank you so much.
Thanks for pulling this together.
Yeah, thank you.
Thank you for having us.
Of course. Thanks, everybody. Thanks, Charlie.